We're going to get started. Welcome everyone to the session Powering Oncology Navigation with Data and AI. We know there's a lot of other sessions that you can go to, so thanks for being here. Hopefully it's inspiring, a little bit emotional, but also educational. So we're going to spend some time talking about a few different things today. One of the things that you'll notice is I'm wearing a lavender sport coat. One, I like the color, but two, it has a reference to survivors and cancer awareness, and is also timely given we're in Breast Cancer Awareness Month. And so today we're going to be talking a little bit about how technology, digital, application of data, plus AI is really helping us transform the patient journey, navigation of certain service lines, as well as fundamentally trying to change the outcomes that patients have for certain types of diseases. With all that said, I want to also introduce myself. I'm Matt Gretzko. I'm a partner at PwC, and I'm joined by two incredible individuals, Jim Graham from NMDP and Jeff Gautney from Rush. With that, what I'd like to do is set a little context. And so to set the stage a little bit, Jeff, if you don't mind, can you just talk a little bit about Rush and your role?
Sure. Yeah. So I'm the Chief Information Officer at Rush, and I wear a lot of different hats. Rush is an integrated university and health system. And so we have all those pieces and parts. I'm CIO at the university, deal with financial aid, admissions, all of those things, as well as CIO at the health system and deal with all the challenges that we face. I don't know if you've been reading the news recently, but in the last 6 months, both of those businesses, higher education and healthcare, have been hammered with change and fundamentally, erosion of some of the things that we base our business model on. So this technology and the ability for it to help us be more efficient and respond quicker and be more thoughtful about what our employees work on is really vital.
So Jim, can you do a brief intro of yourself? And I think we're going to roll a really short video that sort of speaks what NMDP does.
Yeah, thanks, Matt, and thanks, Jeff. And Jeff, you have your hands full with a lot of the changes that are going on, and so hats off to you. Jim Graham, CIO of National Marrow Donor Program, NMDP. And I have the privilege of working alongside of Matt in partnership with PwC. Jeff's organization is actually one of our customers, so you're going to hear more about that in a bit. At NMDP, we are the global leader in cellular therapies. We maintain the United States donor registry for cellular therapies as well. And we're going to talk a little bit about that, but more about that. And here's a video on what NMDP is. Let me take a minute and give you the audio of what you just saw. So NMDP, what we do, think of it as a logical supply chain with cellular therapies being the supply. On one end of the spectrum, we have donors, and those are donors that enter our US registry for cellular therapy. Typically, our donors are of the age of 18 to 35 as our target. And they're on one spectrum, they're volunteers. On the other spectrum are patients brought to us through the likes of Jeff's organization and Rush and oncologists. And the patients typically have one of 75 different either diseases or blood cancers. Think of leukemia or sickle cell anemia. And what our organization does is when Jeff's organization taps us and says, we have a patient, NMDP engages. We have a search algorithm that matches their patients with a donor on our registry. And we provide all of the matching algorithms and logistics to then help the donors give cells to the patients who live healthy thereafter. And that's in a nutshell what we do as NMDP. I'll explain it more as we get into the conversation, but that's what you just saw on the screen.
It's a great voiceover and probably a better voice than they can do. So awesome. So, Jim, you just talked a little bit about what NMDP does. Obviously, you're in a narrow slice of the oncology in terms of hematology and bone marrow transplantation. But, according to the American Cancer Society, right, over 20 million people are diagnosed annually globally with cancer, which is a staggering number and sobering number. But in parallel, they also state that almost 9 million go into long-term remission. So that means is that treatments are working, right? And so if we think about that, Jeff, I'd be really interested if you think about just care delivery overall, right? What are you seeing as some of the challenges in terms of sort of disrupting care delivery now that technology is sort of caught up to what ultimately patients, researchers and everyone needs?
Yeah, it's without a doubt access. Anyone who's tried to schedule their annual physical, something as simple as that, or a colonoscopy, recognizes that there are severe delays in our healthcare system. And there's inequities in our healthcare system. We have a sign on the side of our building that says, who gets to be healthy? And that's the question, right? As a country that we have to answer. Are we prepared to broaden access? What we need to do at Rush is make that as simple as possible and remove the administrative tasks that take up 30 to 40% of an oncologist's time, so that 30 to 40% can be reinvested in saving lives and pushing medicine. As a university, that time also goes to train more clinicians, more researchers who will continue this fight, right? So every little bit of work that we do, whether it's removing administrative burden, increasing access for patients, or improving the engagement that a patient has so they understand their journey, so they understand what's coming next and they can plan for it, and their families can plan for it, removes fear. It removes suffering from the market that we serve. And that there's no higher calling than to think that we have that kind of an impact in Chicago and the region. So we're very, very pleased to be part of a health network that supports, and oncology is our largest service line, our most important service line.
That's awesome. So Jim, I know you recently surpassed your 1-year anniversary at NMDP, but a big focus for you, outside of what Jeff just outlined from an overall complexity standpoint, is how do you incorporate digital technologies? And I think what's a bit unique in your world, and Jeff will speak to it in a little bit as well, is it's not just while the patients are at the core, you've got a lot of other key stakeholders that you're trying to incorporate into that experience. You've got donors, you've got volunteers, you've got skilled couriers. So can you speak a little bit about how you're thinking about the patient at the center, but also trying to factor in how you broaden that experience across all those different components?
Yeah, Matt, I'm going to go back to one of your comments you made, 20 million annually with cancer. And cancer has hit home in my family. I've lost my grandparents with cancer. My mom and dad both have cancer. My sisters had cancer. It's very much a mission-driven sort of calling for me to be at NMDP. As we look at the digital technologies, and having joined about 15 months ago, there's so much better that we can do to automate a lot of what we do. And whether it's our internal organization, and some of our business customers are here today, and some of our business users are here today, providing them better tooling, reducing some of the manual work that goes on. The digital communications that we have with Jeff's organization and other transplant centers, it's a lot of paper, and it doesn't need to be that way. So really providing digital mechanisms to reduce the inefficiencies and really provide the automations and have it be much more seamless as we go forward is one of the things. The other thing I'll mention is we also do a lot of research, and we have a lot of oncology research that's helping with health outcomes. And as we transplant those that are in need, we want to make sure that we're using all of our data, all of our insights, AI, to match donors and patients more thoughtfully together with insights from the past and predictions for the future. And when Jeff's organization comes to NMDP, using all of that insights to really provide great matches for the patients that are there. So it's a lot of really taking our organization, elevating it up with the likes of PwC, Salesforce, more platforms, and really providing that transparency and scale to really help be more efficient and seamless and automated to help more patients annually.
Awesome. So Jeff, I know you have a similar situation that you talked through, and we've been working together about, while again, patients are at the core, you're also starting to think more broadly in terms of how do we apply these digital technologies across some of the other personas. You have providers and physicians, right? You have employees, you have students, right? You have a huge academic and research component as well. So you both have this, interesting dynamic where, yes, you need to ultimately help the patient, but to do that effectively, you really need to bring together all these groups. So you talk a little bit how you're thinking through that, sort of bringing in all those different teams to sort of address a similar challenge.
Yeah, well, right now I'm thinking that I should probably get some Pepsid because Matt's making me nauseous, reminding me that I have a job to go back to and problems to solve. But what I would say is how we apply this this technology to solve those base problems. Let me give you an example. So in our health system, we see, and particularly in our oncology group, we see some of the sickest and most complex cases, certainly within the region and within the country. Through our partnership with MD Anderson, we see patients from around the country and even around the globe. Those patients come with reams of information about their history. It's not unusual to get faxed 200 pages of somebody's medical chart. There is no way that an oncologist or any person can effectively process 200 pages. And you're looking for the needles that are in that haystack. What are the few pieces of information that's in that record that's going to change the therapy that we provide? So that's an opportunity, right, to use Gen AI. It's an opportunity to use workflow tools like Salesforce to find the gems, find those needles, and then summarize that data and have a clinician use it. That's not very sexy. It's not even patient-facing, but it has a huge impact, again, on the time that the clinician is spending with the patient. We're doing a study right now because we've deployed ambient documentation, which many folks have done that at this point, where the physician and patient have a regular conversation with one another, and the system then takes that and turns it into a clinical note that meets all the regulatory requirements and quality requirements and the like. And we're trying to identify what the impact is of that on the patient's experience and on the quality of the outcome, because we think it has a big impact. And we're going to study that in a very structured and rigorous way so that we can report those findings and hopefully help everyone else who's trying to solve this same problem of physician burnout, over too much time spent doing non-patient facing tasks, that we can help solve some of those problems effectively.
Matt, one of the other things, and Jeff just triggered this, is, I mentioned we have donors on one end of our supply chain. We have the patients that Jeff's organization brings to NMDP. We also, once we match the patients and donors, our logistics organization kicks in. And we have recently moved that sort of capability over to Salesforce from a legacy-based system. And what that equates to is when we are extracting cells from our volunteer selfless donors, we collect those actually in a bag. It's a bag of cells. And those are hand delivered to a volunteer that shows up at the collection site. We put those in their hands physically. They then take those cells in a very medically, assigned sort of cooler, if you will, that keeps them at regular temperatures. And they are then hand delivered to the patient wherever the patient may be in the US or internationally. And those couriers are on planes, trains, and automobiles carrying those cells, hand delivering them with their two hands to the medical facility, which then the transplants happen. And so that logistical transformation and just different processes and using technology to really help to transform that logistics is one of the things that's really cool to see now. And we've just implemented it recently, and the feedback's been very, very great. And it's one of the ways that we're taking some of the inefficiencies out of the system to help the overall healthcare delivery.
No, it's great. And I think one thing I'd add from knowing what we did there, right, is I think there's two important components of that. One, you got a tremendous amount of data and insights now that's on a single platform, which didn't exist before. And I don't want to underestimate. We're going to talk in a little bit how important data is, especially for AI, but just in overall in making informed decisions. I think the second piece that you both didn't say as directly is a lot of the comments were around, how do you establish a platform approach now, right? Healthcare has historically been an area where, it's point solutions, right? A certain service line needs to solve a problem, they buy a solution, right? I have a certain need over here, buy a solution. I think what we're seeing is this pretty drastic shift back within healthcare to a platform approach. And Jeff, I know you and I discussed sort of what are your pillar vendors, what are your platforms? And I think we're starting to see that as well. And so if we think about that, we've obviously established this is very complex what we're trying to solve for, right? A lot of moving parts. Care is at the premium, right? We're trying to save lives. But if you might, noting that you've both been pretty successful and starting to incorporate these digital technologies, can you talk for a minute or two, not just why you do it and how you've done it, but maybe one or two successes that you've already seen
because of some of those transformations you started on the road?
Go ahead, Jeff.
Okay. Well, ambient has clearly been a success story for us. I can literally look at the physician's time, where they're spending their time, when they're logging into the system. And for those that we've deployed ambient clinical documentation to, I can see their logins after 8 p.m. at night when they would normally have dinner with their family and then have to keep working. I can see those logins diminish. I can see that online time go down. So I know that that's having a positive impact. I would say a lot of the Gen AI tech that we've deployed in terms of helping physicians draft a response to a MyChart message within Epic, right? So you ask a question, this helps the physician speed up and do a response. We're working on patient summaries. So how do I, again, summarize the information that's available about this patient, do a better job of providing documentation? I actually think that's one of the things that oftentimes gets lost in this because we're so focused on automation and time savings. The other thing it does is it raises the overall quality because now everything's going to be done at the highest quality. I know that's true in our call center. Like I said, access is one of the biggest problems. Well, one of those problems is getting the volume through a call center, right? And making sure that the call center is dealing with the most complicated cases to schedule, not the simple ones that we can deflect and people can do on their own. And so I think that this technology has allowed us to do that, to actually, save calls, stop calls that could be done by a person via text or on their app without having to engage with the human. That means that human can handle more. So our mantra is, because of the fact that there are fewer and fewer people coming into our industry and more people like me that will live longer, develop chronic illnesses, require high degree of care sometime down the road, way down the road, right? But because of that, those two lines are crossing, we have to be able to do more with the same number of people, not with less, because we don't have enough healthcare workers now, right? We need to keep that workforce and keep training them, but we need to be able to do more with the same number of people.
Yeah, at NMDP, we are a growing organization. And over the last few years, we have saved more lives than ever before. We're just coming off of our fiscal year, and we just helped to save just shy of 9,000 lives domestically and internationally by cellular therapy. It's huge. And that's up from roughly 8,000 the year before. And so we are a growing, scaling organization. And I set that tone because just providing simple, complex solutions. And Matt, you mentioned platforms. I'm looking at this in kind of three different ways. We have Salesforce, which is our front-end operations. We're moving a lot of our legacy capabilities over to Salesforce for our operational teams. And really helping to transform how they work, provide more automation, more AI, and much more simpler processes and getting our folks onto the more meaningful tasks. That's Salesforce. We have Oracle, which is really our back-end systems. And moving that over to Oracle Fusion is our trajectory right now. And that's our finance, our procurement, our HR capabilities. And then wrapping that all with data and insights and really helping us providing managed data, foundational data that we then can leverage more of the AI automation techniques. And so we're really trying to simplify our overall ecosystem and do that. And then I'll just drop down into one of the capabilities that we're using some of the AI early stuff on right now. Our donors are in the target age of 18 to 35. That age group, as many of you know, they're tougher to get in contact with. They're tougher to identify with. They're tougher to answer the phone calls. And so when we have our donor specialists reaching out to the donors and asking if they would be interested in donating because they have come up as a match for a patient in need, we want to make sure that we're using our best abilities and AI to predict whether that donor will say yes or no. If they're not going to say yes, maybe we move on to the next and to the next. And so we're listening in on the donor calls with our donor agents, listening into the tone, listening to keywords, trying to predict when that donor will say yes. And we're using some of the AI capabilities and kind of logging all of the calls automatically so the donor specialists don't have to rekey and do logs. And then also coaching our agents on maybe you should have said this instead of that, or a little bit different tone and tenure, or go for the close at the end of the conversation. And so really having the technology and the AI technology and to really help our donor specialists, which is a really important piece of our supply chain. And that's one of the use cases that's in play right now.
No, that's great. And I think one thread from both of what you both just said, right, is everything is, again, how do we drive high quality care, deliver better outcomes? But I think what's nested in all of that is we have to do that without raising the cost. If anything, lower the cost of delivery, right? And I think that's one of the complexities that continues to be out there. I know we've talked about it a lot, Jim, right? Is like if we can drive more efficiency in the process, right, we can bring more of that onto a single platform. If we can lower the cost of care by just a little bit, right, we can save more lives, right? And so I think that's really important. I think, Jeff, some of the things you've said, we're also blowing some holes in things that, a few years back were considered the blockers to healthcare organizations moving forward, right? We know that we've done robust integrations to your EHR, right? A few years back, it was unheard of, right? That's the part that everyone stayed away of, right? You talked about, both of you talked a little bit about, your telephony, and I know, your goal was not to just go with a telephony plan, was to sort of leapfrog and say, hey, we're just going to blow out IVR overall and just go to conversational AI, right? And so I think the exciting part is the ability now, the technology allows us to do very different things than a few years ago, which is a really exciting landscape. So we both started talking a little bit around AI. And so we're going to sort of merge into that part of the conversation here. And, from my standpoint, one of the reasons I work in healthcare is because it's so tangible, but I really think healthcare is really at that epitome of where sort of trust, tech, AI, but that human element has to come in. And I know you both believe this, but despite how much we may ultimately use AI, you still need that escalation path to a human at that critical moment if it needs to be there, and you need to plan for that. And so, if we spend a few minutes, Jeff, we've been working together and we've obviously done the deployment of some AI use cases, but we've also spent a lot of time is establishing the rigor around the governance and the strategy behind that, right? Because it's not good enough to just say I deployed it. It's how do I determine ROI? How do I watch over it? How do I maintain it, right? And determine that this was actually a success. We're delivering ethical care, equal care, mitigating risk, all those crazy things we have to do. So can you talk a little bit, not just about the use cases, but how do you actually think about setting up the infrastructure to support that operationally?
Yeah, so we partnered with Matt's team to really develop a center of excellence, and that center of excellence focuses really in three missions. One is intake and monitoring of AI initiatives. So rather than allow things to just, percolate all throughout our organization, particularly in the university, which is like 3,000 crazy people every single day wanting to do something they shouldn't do. So we gave them a roadmap and a path to come in. So we have intake as part of that job. Monitoring is the second part of that job. So once you release these things in the wild, they don't work like typical applications, where you configure a workflow and it works that way all the time. They work more like a human being. So you give it a set of instructions, it starts to do things. You adjust those instructions as it becomes more experienced, and as the job changes, somebody has to keep an eye on that. And so monitoring. And then the last part, and actually maybe the most important part, because this tech is changing so rapidly, we were talking about this 18 months ago, and what we could accomplish with that tech would be a very different conversation than it is now, right? So, and that's education and evangelism, right? Because the best ideas aren't ideas that come out of my organization. They're ideas that come out of all of the folks that are working with patients and working with students and working in our administrative roles every single day. So if I can educate them about what the tech can do and how to work with us within the COE, that's a huge win, and we get the highest value. The other thing I want to say is in that process, which is like a process, like the journey is the real value, not the goal, not the end point of having, the documentation. How you think about ROI has to really change, because this is not like robotic process automation where I take a process and I automate it. I can very easily say, well, here's the savings. This person was doing this, now they're not doing it, so this person should go get deployed to do something else, and there's my savings. This stuff, it's very impactful across a really large number of people, but this much, right? So my productivity gained by that much. It didn't mean that I could afford to see one more patient. And so how do I think about the value of that productivity? It's a lot more complicated. And so, but you have to be open to it, because elsewise, if you forced every single idea that you had through this sieve of it has to pay back at this level, you would kind of be stuck. You'd be, really stuck in just doing pure automation. So I would tell you that the time you invest to stand up governance, to educate the people that are in the governance, so they're not just showing up because AI is a cool topic and they want to be with the cool kids. You force them to go through the education so they're smart enough to really participate in making decisions and prioritizing work. And then you let that group just go and you let them churn. And I have to tell you, we wouldn't have got there without Matt's team. It was really daunting. And so we, really leaned on a lot of the learnings that PwC brought to us to stand up that group. Now we don't need them so much. Now they're just hanging out with us because now we're the cool kids and they want to be with us. So, but very, very vital step.
No, it's great. So Jim, you talked a little bit about some of the use cases, but I think you're going through a similar process of, identifying the strategy for AI across NMD. Can you talk for a little bit, sort of what's your approach to doing that as well? And maybe speak a little bit. I think one thing we're also seeing is like the industrialization of AI and citizen-led AI, and just any thoughts you have of like, how do you get the organization to grow up with it now, as opposed to it being something that's pushed down? How do you get everyone to believe that this is a new way of sort of operating and meeting the needs?
Yeah, and Jeff, it's a great journey that you just described. I'll talk about this kind of in two different phases for NMDP. But before I dive in there, I'm going to say we're really now looking at our data very, very methodically, and we're doing a data strategy right now for the next few months just to make sure that we have good foundational data and ownership and governance and all of that, and then it's connected across all of our organizational business processes. So think of it as that's the foundational layer. Then our first phase is really stuff that we've been doing for a long time. We've had large language models that are combing through our outcomes of our transplants. We've got data back from the 1980s and forward through all of the transplants that have gone on in the US. And so as we look at how do we better transplant patients in the future, how do we better match donors with patients so they get the best chance of living that healthy life, we have large language models that are combing through data, combing through clinical research, and really providing insights that are doing that. And we've been doing that for a while. So that's kind of phase one. I'm going to go to the next kind of where do we go from here? And that's really where we're at today. We're just standing up a center of excellence for AI. And one of our leaders is actually in the crowd here today, and thankful to have him with us. But we're really setting a crawl, walk, run sort of approach, and talked about the donor journey a little bit ago. But we have to start back. We have to, intake is interesting that Jeff mentioned that. I just got an email right before this that there's a centralized intake that we've merged in with some of our other intake processes. So it's timely. And we're intaking a lot of AI sort of use cases on a daily basis. And so that's great to see. The governance tools, I think we've done just a little bit of an inventory. There's 60 some different tools that have AI embedded in them now at NMDP that we're looking at and going, okay, are they closed looped? Are they with inside of our organization? Are they sharing insights outside and really starting to get a broader handle on that, and then starting to really go at this in a methodical way. And we have one focus area. I mentioned donors. There's a couple of other areas that we're starting to talk through, and it's going to be more of the crawl, walk, run sort of proof of concepts, test it, grow it, find the value, put it into production, and then continuously improve it as we go forward, and then move on to the next case. And that's the journey that we're on. We have a lot of opportunity, just like if most organizations, but it's going to be, let's do it right. Let's get that foundational elements really crisp and clear and move it forward.
Awesome. So I think, we're hearing that we've got some early successes, which is great, right? It's working. But I think we all know there's challenges as well, right? We can always talk about the happy path of here's where we got wins, but there's a lot of failures, right? And we've got to be honest with ourselves. If we think about some of the institutional challenges that we see in healthcare, from a technology stack standpoint, they were built around being static and compliance-driven applications that now need to be dynamic learning applications, right? If we think about the data component, data, more sort of your world, Jeff, that was very focused on episodic and clinical, that now needs to be insight-driven, right, and structured, right, so that we can do things with it, right? And we talked about a little bit of the change management piece of this, right, in terms of where an organization is today and people buying in, right, and not believing that this is going to replace jobs, right? It's actually going to augment their ability to do higher value activities. And so instead of just saying, hey, we've done it and we're being pretty successful, let's spend a minute or two for both of you to help everyone understand, where have you seen the challenges? Where have you seen the failures? Where are the lessons learned? You say, hey, we did do this. It didn't work. We made an investment here. It wasn't a good decision. I'd love to have you both provide some insights there as well.
Well, at the risk of being blacklisted by Williams-Sonoma and never allowed to buy any of their products or all of my products disintegrating before my eyes, I have to tell you, during the keynote yesterday, I had really mixed feelings about the AI sous chef. On one hand, I was like, boy, that's kind of cool. And on the other hand, I was thinking, God, I wish I had a business problem that simple with data that clean that I could solve in healthcare. That just doesn't exist, And quite honestly, the stakes are a little higher, right? The AI sous chef is trying to match a recipe to a product that I bought before. I'm trying to deal with a person who's terrified because of a diagnosis, or they're scared to get the diagnosis, or they're worried about somebody that they love who's not well. That's the kind of person I'm dealing with, not somebody who wants to make a really great pot roast because they've got their family coming over. So, I had this really crazy kind of feeling. And so the stakes are super high for failure for us. And we think about a balanced portfolio because we're learning. And the tech is changing so quickly. We learn this, we get comfortable with it, and then the bottom is taken right out from underneath of us, and we have to learn all new stuff again. So our portfolio of projects, and we think it's important that it be this way, some of them are rooted in things where we know the data set is clean. That's the number one thing. Do we have a clean, reliable data set to build an agent or to operate AI or build an automation around? That tends to be more of the back office functions. However, we also want to do work with the patient-facing ones where those stakes are high. Number one, because we think those are the most impactful things. But number two, because we want to continue to learn. Every time we've done this, we've failed at least 10 times, sometimes 10 out of 10, right? But every single one of those failures, that old adage that was attributed to Thomas Edison, where he found 10 ways that it didn't work, he'll find the one way that it does work. That's how our team thinks of this tech. And so we're very cautious about deploying things that are patient-facing into the wild. And we're cautious about the other pieces as well. And we monitor everything very closely for that reason, because we do expect that we have bad data that needs cleaned up. We do expect that we're learning how to really effectively write the rules and the parameters that allow an agent to operate autonomously. We have a lot of experience with robots. They're pretty simple though, right? They're kind of dumb, do the same thing every time. We have a lot of experience with Gen AI. Again, pretty simple stuff, Gen AI, right? The agentic stuff, you really have to be very thoughtful, very structured, very methodical as you do this stuff. And so we kind of love working on it. And the guys who make that all happen are sitting right there in that row. And the work that they do, all of the failings are critical to this success. You need to figure all of that stuff out in order to go fast. So we tend to go slower than we'd like, slower than I would like. Like Matt, I'm a New Yorker. Nothing's ever fast enough as far as I'm concerned. But those failures are what power us being able to go fast in the future.
Great. Jim, what about for your side?
Yeah, I'm gonna go to the challenges side and hit on that. I think some of the larger challenges, again, Jeff started to touch on this. We are dealing with patients. We're dealing with humans. We're dealing with crisis situations. It's a time in their life when the bottom has dropped out and they're on their last leg. And a lot of times when they're getting cellular transplants, it's their last line of living. And if you think of it in that way, it's really humanizing. And so as you talk about automation, as you talk about AI, we have to be very careful. We have to be very thoughtful. We have to be very diligent about using it the right way and making sure that we're, testing it, proof of concepts, starting small and building it up. So some of the challenges are we have phenomenal business operational folks. And like Jeff's team, a lot of them are sitting here today with us. And they have put their hearts and souls into what they do every single day. They have created processes to help our patients, to protect our patients, patient first sort of mentality. And as you start to talk about AI, that's hard. It's really hard. You're talking about automating some things that I spent a year refining this process to be patient-centric, patient-first. And so really changing some of the hearts and minds and really starting to build trust, really starting to build, automation is going to help. It's not going to replace, it's going to enable me to do even better things, more things, scale the organization, and ultimately help more patients. And it's a really cool thing to think about. It's super hard. The technology, I always say, is the easiest things to change. It's the hearts and minds. It's why we're doing what we do. And those challenges are pervasive as a newer organization and into the AI sort of kind of where we're going. We have a lot of opportunities, but it's going to be a journey.
No, that's right. And I think, one thing that's, often stated is as we think about AI, right, I think there's also some, re-education that people need to have around, there's an expectation of, well, it's AI, it's going to have more mistakes. And I think you said it well, Jeff. I think what we're actually seeing is the opposite, right? And it's got to be a level of comfort now realizing, if you talk about from a call center agent that's a human, like they might give the wrong directions too, right?
Sure.
And so the question is, where can you mitigate that level of risk and say, hey, but if I can have that agent only focus on the calls of people that need to schedule a complex appointment, it's going to be much more valuable than selling them the directions and the potential risk of 1.1% at a time. Maybe they sent the wrong directions, right? So as we get towards the end, of our discussion today, I think this is actually the fun part because this doesn't happen in healthcare, which is let's take timelines and budget out of the equation for a little bit, right? Which we know is never the reality. And you're able to sort of think, 1, 3, 5 years in the future, which frankly, with the speed at which technology is evolving right now, no one can do. But if you take the handcuffs off a little bit and think through, look, if you could do one thing at your organization, knowing the technology that exists and, no money, no timelines, like what would that be? And, whether it's specific to, oncology, specific to your research side of the house, how you interact with patients, just what are some of those thoughts you have that say, hey, this is where I'd like to get to. We may not be able to do as quickly as we want because of the timeline budget, but this is what we think is possible.
You should go first.
Yeah, this is a big question. Let me start back here a little bit and kind of bring the human element back to this. Again, I mentioned I started about 15 months ago, and we have a fairly complex business, and it seems easy on the surface, but it's not. It kind of hit me back, it's been about 3 months ago now, and I had one of my managers in technology come up to me and say, by the way, my son raised his hand and wants to be on the registry, and he's done that. 2 weeks later, he was called, and he is now donating his cells, and I'm going to be going with him to the extraction process. That was one conversation. Couple of days later, and a couple of months earlier, actually, is when it started. We had one of our managers in IT that came to me and said, you know what? Unfortunately, I've been diagnosed with leukemia. And so it was one of those eye-opening experiences that said, you know what? You go take care of yourself. We've got you covered. Your health is way more important. Your job is way secondary. While you've helped thousands of patients in your 10-plus year career at NMDP, we've got you. And so that happened, and some time passed, and he called me again and said, by the way, my cancer physician has come back to us and said, I'm a candidate for a transplant. And NMDP facilitated the transplant through the University of Minnesota facility. That was about 140 days ago. And we followed him like hawks, talked to him as much as we could without getting into his care. And safely to say, he's 140 days out. The first 100 days after transplant are the typical times when you get diseases and have complications. He's surpassed that. He is back at work. And it just kind of brings the human element back into what we do. And that was an aha moment. And underlying all of that is the technology that goes into what we do. And so as I think about how do I continuously make our organization better with automation, with AI, with better processes, better tools, techniques, whatever it is, it's really taken what I said earlier, and it's simplifying our overall ecosystem, moving a large portion of our operations onto as much automated Salesforce as possible, really helping to have the data connected and enabling a lot of the AI that we've been talking about, taking our back end, moving it to Oracle. I won't dive that any deeper. And then wrapping that all with just streamlined processes that are transformed, eliminating all the inefficiencies, having our awesome business users do what they do at the highest end of their license. That really provides the most patient-saving opportunities for the healthcare ecosystem.
Jeff, anything to add before we go to our last slide?
I would say our vision is kind of simple. And if you say money is not an object, that's awesome, because we can spend a lot of money, believe me. The vision is really simple. This is the clunkiest version of AI that will ever exist. Next week, it'll be better, right? Next month, it'll even be better again. And so my vision 3 to 5 years from now is that the tech has removed a lot of the wasteful and silly things that we wind up doing in healthcare. And it's sort of disappeared into the background, allowing better, more meaningful, and more personalized interactions for our clinicians. A clinician who's seeing 8 to 10 to 12 patients a day, you'd like to think that they've studied your entire record and your entire family history, but it's not set up to make that possible. This is the first time there's technology that actually could help a physician be as prepared as they could possibly be when you're talking to them. So that's my vision, is 3 to 5 years from now. We're not really talking about this stuff because it's sort of seeped into the background noise of just how we work together. And it's not this artificial intelligence that's, I'm wrestling with, it's going to have my job or it's going to influence what I do. It's just, yeah, of course. Yeah, I use Waze or Google Maps. Of course, that's how I get from point A to point B. I use the weather app. I don't think about it, all the machine learning and artificial intelligence that goes into creating an accurate forecast or even a hyper-accurate forecast, right, by zip code. I just accept that that's how I do that. And I think that's where our biggest, it's going to be a rough period to get there. I think we're going to go through this cloud of agents that are fighting with each other, by the way. About 24 months from now, it's going to be like total chaos with agents. But leaving that aside, once we get to the other side of the agent battle, we're going to have this tech that is just enabling. It's part of our lives, much the way as it has become on the consumer side. Like I said, you wouldn't think about getting from point A to point B without looking at an automated map.
Right.
Nobody has maps anymore. We have phones that tell us where to go and where to turn left, where to turn right. So that's what technology in our business needs to get to, so that our faculty are spending more time with students and training the best possible clinicians for the future, so that our doctors and our nurses and our therapists are spending the most time that they can providing the most personalized care that has the best outcomes. If we can do that, in 3 to 5 years, that would be, I would actually retire at that moment, because I would say my mission is done. I've given it 45 years. Took 45 years to get to this spot. I'm cool. So
that's awesome. Well, I think we're going to wrap here. We have one final slide. I think the challenge we'll place with everyone here is, we spoke to how sort of NMDP and Rush work together. I think one of the things we're seeing with these new technologies is not just the insular, how do we improve the experience, but how do organizations to organizations work closer together and really transform the way we deliver care? And then I think the final slide we're going to put up, Jim, is maybe if you want to do a call and an invitation to everyone that's here today in terms of how they can get involved with NMDP.
Yeah, NMDP is really philanthropically, we're looking for folks to help. And if you're interested in joining our registry, let me know. And you can scan the code here, and that will help you. We're looking for typically folks in the 18 to 35 age range as our sweet spot. The other thing is if you're interested in donating to NMDP and helping with some of our clinical research, helping with families in need that have large care costs when they're going through a donation of cells, we'd be happy to help. If you have any questions at all, let me know.
Awesome. Well, thank you everyone for being here. And Jeff, Jim, thank you for the amazing mission and work you guys do at your organizations. And thank you all for coming.